Great. Okay, so you're all very welcome. I'm going to start by just introducing Darren, who is our digital programme lead for the Encompass, and let Darren take over at the very beginning here of the slide deck. And between the two of us, we'll do a double act. Thank you, Darren.
Hi, everyone. Thanks for coming along today. So Linda is actually driving the slides here, so I'm going to call out next slide whenever that we need to move to the next one. The next slide, Linda.
There you go.
Okay, so I presume most of you know what Encompass is, but this is a slide deck that we use for many different scenarios and many different areas that we're talking to. We've done this a few times. So it's what is Encompass? Obviously, we all know it's a clinical and operational transformation program. It is not an IT project. It's a clinical and operational transformation program with Epic's health operating system at its heart. So Epic is obviously a world-class leading EPR, and we're adopting it for the whole of Northern Ireland. It will also change how staff do their daily work across the trust, massively change how staff do their work, and will also change how patients and clients participate in their own care, which is an important aspect of this and something that we will be seeking to grow. So just for clarity, Encompass is the name of the program that we're delivering. Epic is the software that we're installing. Okay, so if we go to the next slide. So why do Encompass? Health and social care has currently lots of different systems, and it's probably something that the public didn't really realise. That there's different PAS systems, there's different lab systems, there's different outpatient systems. It's the slide before that, Linda. And that's been a challenge up to now, because that has meant many different similar conversations with our members of the public as they come in. And the idea about Epic is to provide a single source of that patient client information, so that conversation with the patient doesn't have to be again and again repeated and information that the patient's thinking, well, I've already told the person whenever I come in the front door, and now I'm taking down the x-ray and I'm telling them the same thing. They don't realise that's all different systems. Some of them integrated, some of them not. But this will ultimately provide a single source of the truth, albeit with tight integrations with the likes of NIPACs and NIPIMS and so on. So this next slide that we're on now, it is a fundamental change for the way of working for all of our staff. I'm not going to slavishly read out each of these. You'll get the slides as you want, but an example of that would be porters, say, for instance. Right now, porters, some areas would have electronic portering information, some areas wouldn't, and it would be literally bits of paper or a telephone call or a Vasera badge call to those porters to go to a ward to pick up a patient. Now, if something happens to that patient in the meantime and they have to be taken to a surgery, emergency, or something happens to them, that porter will still not know that. They'll end up at the ward and they'll try and find that patient and they're not there. So that's really inefficient. It's as efficient as it can be today. But with our porter colleagues, they will receive instructions via mobile device when they're going about. So if there's any cancellations, they will get that via their device, and there'll be a really efficient way to move the patients around. Another one I'll just pick here is ED doctors. So ED, very, very fast moving environment, as we all know. Don't know what's coming through the door at any moment. And the quick access to that patient information is critical for them, including current medications and things like that. So having that all in a single system, once we're rolled out across the whole of Northern Ireland, will be incredibly beneficial to both the ED doctor in terms of finding that information, but also to the patient as well, which is the main reason for doing these things. We'll move on to the next slide. So that was the fundamental change for everyone, and Ratiel later will get into the benefits in a little bit more detail, but this is a very high level benefits for all piece. So there's benefits for staff and there's benefits for patient and clients. Again, I'm not going to read them all out because they'll come into more detail with Ratiel's presentation, but the key one for me is the top one there for staff. More time spent on what is important. So you won't have to spend, our staff won't have to spend time looking for information, logging into different systems, trying to find that lab information. They should find that at their fingertips in Epic. That will release more time to care for the patient, which is what we all do. An important point about that is Maybe not initially, but that won't be the case because we'll be getting used to Epic. Everyone will be getting used to that system. So there might be, and there will be, a slight downturn in activity over that period of initial go live, but we will more than pay back as we go forward. So that's for staff and for patients, as I've already said, less repetition and repeating multiple information to multiple healthcare staff, and there's an increased ownership of the health journey. So the public will get access to the patient portal, MyCare, which we'll touch later on in this presentation, and that will empower them to actually see a lot more about their information, take action themselves, ask questions of their healthcare professionals, and get direct responses from that. So that's a massive uptick. In some areas, we've had that for the likes of renal, but this will be for all patients ultimately, which is a massive step forward in terms of the benefits. At this point, we'll pass over to Helen for the next slide, and Helen will do the next few slides, and then it'll come back to me.
So no pressure, but we're sitting at 34 days out, and this is the time to hold our nerve and keep going forward. And this has been a very long journey for some people, for years. So to actually see us down in single figures was quite a shock a few weeks ago, and now to see less than 40 days and sitting at 34 days is monumental, and that includes the weekends. We're not talking working days. So it's just so that everybody knows how close we are to go live. Next slide, Linda, please. So I suppose we are moving forward on the shoulders of others. And recently we had occasion to meet with a number of different sites that have gone live. And the one thing that we hear is, whilst this brings significant challenge to the whole system, because it's not, as Darren said, digital, it is a transformation of how we do our business for our patients. It actually is worth it. And no one that I have spoken to at any level in any organisation has said that they would go back. They would never leave the Encompass system that they have in Epic and return. That whilst it's challenging, the prize at the end is worth this pain now. And that's, I believe, what we are holding on to tight, because this is difficult. It is not an easy journey, and we just need to keep our nerve and keep moving forward. The important bit is this is a Northern Ireland-wide implementation. We are the first of that, I believe, globally. We are the first country to actually go with an integrated health and social care system where both our hospitals and our community services will have the record within the Epic system for Encompass for our public and our staff. We were chosen as first to go live. We have worked on other major schemes. We have a strong programme management record, and it was decided that we would go first with a very strong phasing, which is very clearly within the next 2 years, all of Northern Ireland's trusts will have their patient record in this. We are being very closely watched by partners globally. There are other organisations who want to come to our Go Live, and they want to learn from us, whether that is Royal Devon and Exeter in England or others, because they see merit in this concept of a country-wide implementation for a region or a nation. So it is important that we get this right. In terms of our own trust, just for a recap, the South Eastern Trust serves a population actually of 370,000 approximately within its catchment, which is 19% of its population of Northern Ireland. But when we take in others who come for both regional services and locally to us in Belfast, we're roughly around 440,000 people who come to receive service in the South Eastern Trust. We cover 3 government districts, so this is quite a significant start to the rollout. And only this morning, communication went to chief executives of councils to explain to councillors and also to our local MPs and MLAs. And in turn, each council area and each MLA, MP in Northern Ireland will become aware of this as it goes into their particular areas. So it is a significant population that we're catching already in phase 1. Next slide, Linda. So suppose just so that everyone is aware of what the services are when we say integrated, and for those that may watch this back, 80% and well over that of our service needs are delivered outside of hospital settings, but we do have an acute hospital at the Ulster Hospital site in Dundonald, with local hospitals and a community hospital supporting us both in Lagan Valley, the Down, Ards and Bangor. but there are over 100 facilities that we're going to have Encompass within, and also in community settings. We also provide services to prison healthcare, who will eventually come into this scope as well. And we have over 11,000 staff who will actually be within this system. And they themselves, some of them and their families, will be patients who will also be receiving care, and therefore will have access to the service of this Encompass from the user end as well as a staff user perspective. So we have significant service coverage, which is also a great test of this Encompass system. And as I say, the likes of Finland and England are looking to see how that will work in their own areas and want to come to go live to see how it happens. Next slide, please. So how we're managing go live is really important. We've had many phases to the programme, but right now in these last few weeks, we have had to revise the entire structure of governance around this. And this is important because we would have taken from the learning from other organisations what works. So Ratiel would know from other organisations that we have been in connection with, and that we have taken what supports them and does a good go live. And we've also learnt from what EPIC have recommended. So we obviously at the every single operational group, and there are a significant number of those in the bottom purple box, which I don't expect anyone to be able to read, but every single division and every single directorate has an operational go live readiness group. That is feeding up into a trust group. And alongside that, there is another whole structure has been established, which is over towards the mustardy coloured box of a go live planning committee. And that planning committee are now the team that are preparing for the hundreds of people who are going to come alongside us to support us for go live. The one thing that is very evident from observing other go lives and speaking with others is that when you are part of the EPIC community, you're part of a global family of people who want to see something work. They know it's worth it, and they are prepared to come along and support us and give us their experience and their expertise to help to go live. That is really important, and that is called pay it forward, pay it back. So we have been to the likes of England to help them to go live. They are coming back. Likewise, all of you on this screen, I know, have an interest in this. Some of you have more than an interest. Some of you have put your hand up and have become super users and want to come and be super users or floor walkers. Some have come to support us on our technical dress rehearsals. All this language we have had to learn, but all of it, every single one, is another step closer to go live. All of that feeds into our Trust Encompass Programme Board, which ultimately reports to our executive management and up to Trust Board. And alongside that, via the Regional Encompass Delivery and Readiness Board to the Regional Programme Board and up to the Permanent Secretary. So there are a number of groups. We are now, on average, our directors are meeting twice a week for huddles on Encompass, but every single day, directors and all of the trust are working on Encompass. And our diaries have flipped that the priority now is Encompass. So even our chief executive would spend approximately 3 to 4 days on Encompass alone in terms of activity for preparation for go live. There are many things coming in at this stage, literally to land for go live. So it's just some of the learning that we've taken from others. This is a really important structure. We're prepared to share anything that we have learned, any documentation, governance-wise, or anything else that we have done with others, because it's bigger than us. We're just phase one, and we don't want anyone to have to learn what we have learned. We want to just give it as a gift to everyone who needs to do this in Northern Ireland and further afield. I am the senior responsible owner, and alongside me, I am supported by professional leads. So those would be our Chief Nursing Midwifery Officer, Medical Officer, Allied Health Professional, Social Work, to name those, and Pharmacy. But alongside that, we also have director sponsors leading a range of groups, and then Darren as the lead digital technical, and Naomi as the lead programme, Naomi Dunbar. Next slide, please. Suppose just to put a bit of practicality to what I mean by governance. We have a meet the date or escalate. So I said to you, we've learned from others. So we had the privilege of having Emily Barry, who is the nurse evangelist and vice president of EPIC. And we asked her practically, how do you actually get this thing moving? And she suggested that in preparation for our go live command structure, we needed to start doing a top 10 at 10 or 12 at 12, whatever time of the day worked for us, of top tier problems that are coming through from each of those groups that I referred to. And those problems would have arisen because we'd have set a date for a decision, set a date for an action or completion of something. And if that date had not been escalated, that needed escalated to the top 12 at 12, so that our chief executive and directors, along with our professional leads and anyone else who's relevant to the particular topic, comes to a whiteboard. We go through the problems and we literally, it's an action-driven, very agile process to get to what's the next step we need to take. Is it bigger than us? Is it within our gift? What do we need to do? The aim is to promote rapid decision making, promote feedback loops between ourselves and the patient bedside or carers or whoever it is that we're supporting. And that is really, really important. That is one thing I have learned, the speed with which this is coming down into day zero. And from day zero, when we launch EPIC, how we will deal with making the most of this programme. So that is a two-way traffic. We make a decision, off it goes, we seek more information, whatever it may be. But those huddles have been fundamental to the success of us clearing the way for go live and clearing problems. And it was just a suggestion that we were given and we have found has worked. So as I say, we're back to 34 days to go. We know that go live is only the start. We just need to know if it's good enough to go. And I'm going to hand over to Darren, who's going to talk a little bit now about the readiness and good enough to go stage.
Okay, just conscious of time, I might move through these quite quick because we're might be a wee bit close for time. But in terms of user and system readiness, there's a number of areas that we have to focus on to get across the line. But the 5 key ones are on the screen. Staff training. There is a principle in this that if you're not trained, you do not get access. So that has a strong implication on our go live. We have to make sure that we have to train people, and that is a massive undertaking with the tens of thousands of people that there is in Northern Ireland. So staff training is a key one. Manual data migration. There is a process doing electronic data migration, but there's inevitably, as we all know with our systems, not all systems can be electronically migrated. There's inevitably an amount of data that will have to be manually migrated. That is literally a huge team of people sitting with a computer with 2 screens, the old system, the new system, and manually migrating stuff across. And that's like the estimation of the figure. We hope to bring this down with the electronic side, but the estimation of the figure is something like 40,000 hours of people doing manual data migration. That's a mammoth task, and we thank the team that's looking after that at the moment. TDR, which is one that I'm focused on at the minute, technical dress rehearsal. That's where it's interesting saying about the go live on the 9th of November. My go live was at the beginning of September because that was I was responsible to get the TDR team out to go and test every single computer in the whole of South Eastern Trust, every single printer, every single lab label printer, to make sure it's working in anticipation of the go live. And of course, we would flush out problems and get those fixed. So that's what I'm actually doing right now. I stepped out to do this call. So TDR, that's the vital element. MDI, medical device integration. There's a numerous amounts of medical devices that we have across the health service that are integrated to various systems. They will also be integrated to EPIC, but many more stuff that was never integrated before will be added. And that's a big uplift and a big piece of work that has to be completed. That piece is actually going really, really well. So we're okay pleased with that. Workforce transitions in an interesting one, because at the start of the slide, we talked about changes for all staff. There is some staff, fundamentally, their job will change, particularly around admin staff who, and the movement of notes and things like that. Those notes won't exist going forward. So there's a huge piece of work with our HR colleagues to make sure there is nothing in this business case about removing staff. So there's a huge piece of work in that process to make sure those staff are looked after and moved into other roles and upskilled for those other roles. So as we move on to the next slide about resources, to give you an idea of the cost here, the programme as a whole is 280 million across the 5 trusts by 2027. And to give you a small snapshot of South Eastern Trust, we're deploying 8,000 new additional devices in our network. And that equates to about £6.3 million worth of spend for fixed devices and mobile devices. And to give you an idea, typically we would spend £1 million to £1.5 million each year on new devices and replacement devices. So that's almost 6 times the number of devices just for this one program to supplement what we have. And as I've already said about the staff, there is a number of significantly impacted staff that are being considered for alternative posts and as a result of implementing Encompass. And hopefully that is seen as opportunities for those staff as things move forward. So risks to mitigation, some of the key areas that we that are risks for us, and I'm sure many of you are aware, there's interdependent programs here. There's the NIPINS program, which is the lab system, which is due to go live in Belfast before us, and then we're going live on the same day, 9th of November. And there's very strong links with those programs. Radiology with the NIPAX Plus program, there's elements of that are going live at the same day with the phase 2 element of that. So those interdependent programs are very interdependent, and if there's a change in EPIC or a change in the Encompass program, it can affect labs or radiology, and similarly, if there's a change in labs or radiology, it can affect this program. So those are carefully managed at an SRO level going forward. And there is challenges there. We have to be honest, but we'll support each other through that. One of our main risks, as alluded to, the 100% training piece. Our training uptake is not where it needs to be at this point in time, and we're working hard to get that turned around with our staff. Completion of build, even at this stage, some of the areas are not completed in their build, and there'll have to be an escalation there to get that across the line, or even a potential discussion of what could go live. Oh, the slides seem to jump forward too there. So we'll move on. Oh. So there's some mitigations in place for some of these things. Regional support for getting these risks across the line. On assurance of the program, we've had gateways done for the program. We've had internal audit done for the program. Our internal audit just recently completed and give us satisfactory with only a couple, 2 or 3 nine. Sorry. That was maybe by mistake. And just one point I wanted to make about this was this middle one, Encompass business continuity arrangements. It might sound like a risk putting all your eggs in one basket, one electronic system to rule them all, that if anything ever happens to that system, we're scuppered. That's not quite the case, because I've never seen business continuity arrangements, electronic business continuity arrangements that this system has. There's multiple tiers from the data center down to the local data center, down to individual PCs. They're spread across the air with UPSs on them. That will mean that having to go back to paper probably shouldn't need to happen unless there's a really, really major thing. So yes, there's a risk with moving to a fully electronic system, but the business continuity elements in this system are such that we've never seen before. So I'm really pleased to see that. So that de-risks our go live. So move on to the next slide, which is communication and engagement. Helen or Jane, who do you want to take that?
Jane, work away there.
Hi, I'm Jane Lockery, and I'm the head of communications in the trust. So it's nice to have a chance to chat. Well, obviously it's a huge program, as Helen and Darren have said. It's a regional program, and we are the guinea pigs. We're going first. So hopefully we have set the right tone in all our comms that we have done, which is exciting, innovative. This is, a digital innovation. And we have, obviously, if any of you is on our social media, you'll have seen us ramping up the information that is going out. But and we have tried to, for example, talk to our staff straight after their training so that they're able to talk about how beneficial it is, to encourage other staff to come on, because both the external comms on this and the internal comms, I think, are both equally important, because the staff need to know what is happening and what the ask is of them. And also a big fat thank you as well, because they are doing such a sterling job. So we're very mindful of that and everything that we put out to our staff. And again, we've got our staff engaged with our social media, and they have taken part willingly, inverted commas, in many videos. Whatever we tried to cover each directorate. So, for example, this week coming, we're going to ED and to maternity to film there about what a difference that Encompass is going to bring. To those departments. We've covered everything. We've gone out into the community. We've videoed our district nurses with their new robo devices, and they've discussed, for example, how it's going to benefit the community, because I'm very conscious this is right across our trust. It is not just hospital based. And we've also talked to people, for example, in Royal Devon and Manchester. We know we've teams from our trust have gone over there and we've asked them to take little videos on their phone. And people have all said unanimously that they would never go back to the old paper system. And we've put out those videos as well to encourage people that yes, there is some pain. I think that Helen and Darren would agree with that in getting this over the line, but the gain is enormous. And there's actually a member of our ED staff that we've also videoed. It seems like that years away now, a couple of months ago. He had use of a similar system in Canada. And I thought that was really good to talk to her and about, and again, she said, you know, she would never go back to the old paper system. So it's lots of work to do. And hopefully some of you have been on this dispatches will have seen some of our social media and have enjoyed it, because it is there too. It is, we try to be as engaging as possible, because if you're not engaging, people aren't going to click on it or read it. So
thank you, Jane, and I'll take over now. So Linda, just to bring it into conclusion, just one other thing I want to say about engagement is that we are preparing for our go live, and there's a very practical plan for that. And we have worked with our commissioner. They are aware we need to give staff time to get used to this new system, as well as obviously ensuring that people are trained. We also want to have people at their elbow to support them as they have the first days in this new system, but keep patients safe, staff safe, records appropriate. So we have asked for some downturn of activity. We know that I have worked with my director colleagues, and I know that the operational directors have worked with theirs to ensure everyone is sighted on that plan and understands how we plan to hold a position, but also rapidly get back to pre-Encompass activity levels as quickly as possible. That will obviously go out as part of our communication and giving you your place as staff to understand that. Next slide, Linda, and it's just very briefly, just to remind everyone that we have a new patient portal, user portal, that will be created called My Care, which will go live. Engagement Council worked to get the name of that. If you're in America, it may be called My Chart. It's called different things in different places. Next slide, please, and final slide, I think, which is the slide to do with how you get access. And obviously part of the communication will link to how do you get access to that. So if you have a live record at the time of go live, it will be transferring in. So it's not that every single citizen in Northern Ireland will have a full My Care record. It's not like that. It will be as you are exposed to care need, health or social care need, your file will start to get created. And then there's a process for logging in and creating your My Care app link. And that will be transformational for our public and for us as staff, how we engage with people. They will become much more interactive with their care. It will allow us to, for example, send promotional materials to explain and hopefully, for example, increase the uptake for screening or for compliance against health development material, health promotion material. But that's all for the future. Right now, Darren, Jane, I, along with everyone else in the South Eastern Trust who may be on this call and everyone else who is supporting us regionally and nationally and internationally, we're in day 34. We're on the way down to the launch pad. We will be going live on the 9th of November. See you all soon.
Thank you.
Thanks very much, Darren and Helen. We have lots of people on the call. Has anybody any burning questions that you would like to ask before I hand over to Ratiel? Just going to check the chat. Okay, surprisingly, no burning questions. I think that's because you were quite comprehensive to show what structures you have in place, Helen. And it's great to see that you've done the learning from others and have adapted that for South Eastern Trust. And I'm sure other Trust colleagues will be reaching out, asking for your own specific lessons learned. Okay, I'll hand over to Ratiel. Ratiel, you're going to talk to us about the benefits piece from Encompass.
That's right. Thanks very much, Linda. I'm just going to share my screen if that's okay.
Perfect.
Just open it up. we go. Okay, let's move this up. Right. Okay. So, hi everyone. My name is Ratiel Gapa. I'm the regional benefits realization lead for the Encompass program. I've been with the program since June, and I was asked to come over today and provide you with a general orientation on benefits realization or benefits management. So I'm hoping that my rather high-level presentation will meet expectations for today. Some of you will already know the area, so do please forgive me if I'm teaching you to suck eggs, but I'm hoping that this will enlighten the majority of people. So where to begin? I'll start with the obvious, right? Which is that generally, change is indeed necessary, but often difficult, unsettling, and indeed painful. And it often does need significant amounts of planning. And what's also obvious is that even in our lives in general, we rarely opt for change unless there are clear gains or benefits. And examples I've given here include, the stress you go through when you're moving house, for example, right? To gain more living space or to be closer to family, or the pain of, the health regime to achieve weight loss, for example. We wouldn't put ourselves, through difficulty and pain unless there are clear gains or benefits. And so the same goes for organizational change as well, which can be unsettling and difficult, but which is generally undertaken in order to achieve clear benefits or gains. So what exactly is a benefit? Well, by benefit, we don't mean universal credit or job seekers allowance or housing benefit, etc. Here, a benefit, we refer to it as a measurable gain or improvement perceived as positive by one or more stakeholders, which contributes to organizational strategic objectives. It's really a response, to the questions, so what, why do I care? Why should I care, right? What's in it for me? A benefit is a response to these questions. And so it follows that benefits management is the process of identifying the gains or the benefits of a change, assigning a value to the benefit or to the benefits, understanding the current levels of performance to be able to compare with the future, and monitoring and reporting on impact. That's what benefits management is about. Next slide. So why benefits management? Why is it necessary? So as the Project Management Institute, PMI, identifies, actively managing benefits contributes to better projects or program outcomes. It helps to ensure that project aims and objectives are more clearly understood by everyone and more successfully delivered. It also helps to make clearer the link between the program and, in this case, HSCNI strategic objectives, for example. And benefits management also helps to demonstrate and to evidence a return on the investment made, in this case, with EPIC. And finally, benefits management also helps to align with best practice. Indeed, benefits management is a discipline or an approach that's used widely across the public sector, and it's advocated and contained in the Green Book. And just so you know, the Green Book is government guidance that provides a framework for managing programs and projects in the UK. Now, very often, when the business case for change is made, it is expressed through 5 distinct cases. You've got the strategic case, the economic case, the financial case, the commercial case, and the management case. And benefits form a critical part of the business case, particularly in the economic case, to support cost-benefit analysis, and in the management case, where a plan and governance arrangements needs to be clearly outlined. So that's the why of benefits. The next question to be asked is, how exactly is benefits management carried out? How exactly is it undertaken? And I use Stephen Jenner's 5-stage methodology, which is widely used again in the public sector. It comprises of 5 stages: identify and quantify, value and appraise, plan, realize, and review. So first of all, you look to identify the benefits that you're aiming to be able to realize, and then you want to be able to value, to fully analyze these benefits and try to assign a pound value as much as possible to these benefits. And then you proceed to develop a plan for how these benefits are going to be realized. And then you work to monitor and to track actual realization, and then be in a position to do a look back, to do a review in terms of lessons learned and construction or development of the post-investment report. And I tend to use this slide just to sort of demonstrate the range of outputs that we're aiming to produce as part of the Encompass benefits management. This includes, benefits profiles, which we've started to develop, the benefits financial model, which I'm currently building, the benefits register, which contains all our benefits, and then the planning material, the benefits realization plans that I'm developing for both the short, the medium, and the long term, as well as possibly trying to work out if it's feasible for us to develop some sort of dashboard that we can use to be able to report on our benefits. And then at some point, I expect that a post-investment report will be required to demonstrate the extent to which our benefits have been realized and the extent to which these have provided a return on the investment made. So I threw in the slides just to highlight the seeming sort of dynamic nature of benefits management. And I often do explain to people that, benefits management is, as a discipline, is equally a science, a craft, and indeed an art. As a science, it's driven by the logic of the 5-stage methodology and involves value calculation and forecasting and so on. As a craft, it's because you get better as you practice it and you learn from your peers. And as a benefits professional, you are also subject to professional certification achieved through foundation and practitioner examinations. And as an art, that's because it involves a lot of soft skills around engagement with subject matter experts, defining benefits and being able to support towards a compelling case for change in order to secure the interest and the involvement of the different stakeholders. So in terms of an update, so where are we in general? So we have a total of 37 regional benefits. And again, just to emphasize that these are regional benefits as opposed to just sort of being set benefits. The benefits to cover the entire region. And you will see from here that probably around 70% of our benefits are either sort of cash releasing, income generation, or non-cash releasing. That means that about 70% of our benefits will need to have a value associated with them. And again, I'm in the process of developing those values. The 30% qualitative benefits won't necessarily need to have financial values. But again, from this chart over here, bottom right, you can see that our benefits do generally cut across a fairly wide range of themes, mostly patient safety, productivity and efficiency, cost saving, and quality of care. Now, in the short term, we're looking to immediately start reporting on any realized benefits as soon as possible. As soon as we go live, we're aiming to start looking, for these. And this will be in the form of sort of data, case studies, user stories, testimonies from staff, or indeed from patients as well. And in the medium term, we expect to continue, again, throughout with the gathering of data, developing of case studies, user stories and testimonies and reporting on all of this. And we're looking to be able to develop a sort of Encompass yearbook, which is similar to the one that they did over at Frimley, which I've shared already with a fair number of you. The Frimley one is really quite good. It's very interesting. It's essentially a visual collection of case studies, stories, and diary entries highlighting the benefits realized in 1 year of using Epic. I'll aim to find a way of sort of sharing that yearbook even wider. And in the long term, or in the medium to long term, we'll be looking to evidence and reports on realization of financial and indeed non-financial sort of benefits. And so we are working with Southern Trust as well as the other trusts to develop realization planning for the short, the medium, and the long term. And so at this point, I really just want to commend Southern Trust for the great work that they are doing in supporting and in fact leading with the review and development of our regional benefits. Thank you very much, Southern Trust colleagues. A really good effort. So there's 3 key actions that we are pursuing. So firstly, we're actively gathering current performance data, so we'll be able to compare obviously with the future once the change has been fully implemented. Secondly, I am looking to engage the trust as well to try and identify and catalog those benefits we expect to be realized early, so that we can generally sort of work to plan for that. And then thirdly, and this is an upcoming sort of a key action which will require your support. As I said, we'll need to draft case studies, user stories and testimonies and so on of positive impact. So do please be prepared to offer any support you can towards that. It's really important that you please shout out all the successes that you experience, from Epic. This will indeed demonstrate how worthwhile the undertaking is and will serve to motivate the others as well. Just 2 more slides I think I have. One more slide actually. So this last slide shows the governance arrangements we have for Encompass benefits management. Put simply, we have the benefits board, which is right over here. We have benefits boards, which meets on a monthly basis with representation from across each trust. And the benefits board is chaired by the Chief Digital Information Officer, Dan West. And then we expect to also set up a platform to oversee, coordinate, and maintain the regional approach to benefits, and it's at this level over here. And so discussions are in progress effectively to try and identify the best platform for that, as per sort of recommendations I got from the DOPS on Monday last week. And then we also expect to have benefits working groups in each trust. Southern Trust have already set one up, and we've got a meeting on we've got our monthly meeting on Monday afternoon, and I know that Belfast are looking to do the same thing as well. And so that's the benefits board sitting here at the top. The regional one will be sitting over here, and then the individual sort of trust benefits working groups are these ones, potentially comprising of these different sort of individuals plus others. And then I have recommended that it may be a good idea to also have a less informal or a less formal platform for peer-to-peer support and for benefits learning and best practice. And so I thought perhaps setting up a benefits community of practice would be useful. It's not set up yet, but it remains the intention to do so. And that's what you see right over here. So that's my benefits management orientation. As I said, apologies to anyone who already has sufficient knowledge of the area, but I hope this goes some way to fill any gaps that most people have about benefits and benefits management. And I'm open to any questions.
Thanks for that. I'm actually just glad to see that it's being mapped now. It's one of the things that we're traditionally very poor at across HSC, and I put my hands up to that as being a project program manager for years. So Ratiel, thank you for that.
No, you're very welcome. I mean, to be fair, it's an issue which is, it's a challenge which is prevalent in many other different organizations in the public sector. So you're not alone there. Yeah.
Okay. Helen, there is one question that I would like to go back to that is relevant to some of the planning that is going on in SET at the minute. We have a question in around have departments within SET reduced the staff numbers on annual leave to aid with the increased staff numbers on the floor during the go live period?
As I said to you earlier, all of you, we have done a number of major transformation pieces, whether that's opening new hospitals, or in this case, commencing a new way of working, and be it digital, not bricks and mortar. And one of the things we've learned over the years is that obviously we work with our staff. We recognise our staff have gone so far above and beyond to help us here, but I think that they can see the win. And many staff have said they wouldn't dream of wanting to take leave because actually they want to be there to see this thing go live now because they've invested so much time and effort into it. The other thing is that we recognise life happens. People may need bereavement leave. They may be going away to celebrate their sister's wedding, whatever it might be. We work with our staff. So the way we take a very pragmatic view each time, and we have asked individuals and line management to consider how they best believe they can build the resource in around their team for their division, their department, their ward, whatever that might be, to ensure that they have supported their team and that their team feel ready and able to go with their go live. It's a small period of time, and there's a reason we went with November the 9th, because it gives us a good run before Christmas to get this thing to go live. We didn't go for like the 25th week of December being 2 weeks later. There's a reason we've gone early in November. We know that people are still entitled to their leave, but we are trying to work with each team and each individual and each division and directorate to ultimately keep patients safe, keep staff safe. But the amount of offers, I have to say, the amount of offers that I have had of people to come to help support is actually quite humbling.
Great. I'm curious, just because I do come from a training background, around the challenge of getting so many staff trained. Helen, can you tell us a wee bit more about that?
That has been a programme in itself, Linda. The message we got loud and clear from EPIC some time ago was no training, no access, no kidding. If you are not deemed to have received training, you are not actually given your login, therefore you cannot access. So the pressure is on to be trained in this system, and training is dependent on your role and your responsibility, and therefore what level of access so it's not a blanket one training fits all. And we recognise that we will have to train forever. That new starts, new people coming in will require training, so there will be left behind a permanent training team. It took a lot of choreography to actually identify training rooms. Trainers were credentialed trainers or principal trainers were employed by the Encompass central team. However, recruitment initiatives were difficult, so we had to find staff to help to shore up training, as well as keep the lights on, do the job that we're here to do, which actually is deliver health and social care. So we had to also help to produce the training book that tells you what type of training is available for whom. And it's so important that we actually have one director who is the lead director, that is David Robinson, the Deputy Chief Executive, has taken on the responsibility of coordinating and overseeing the training with the regional team and the local team. It is regularly monitored, as in every day, and reports are produced 3 times a week for directors like myself to know exactly how many people remain untrained, how many have still to book on, how many have passed. If people have tried to book on and have struggled to get booked on, they create what they refer to as a VFAR, How many of those are in situ and still need resolved? How many have tried to log on at the end of their training and have a VFire created because the log on's not working? This is monitored to the death, Linda. It is like training I have never witnessed before. It's a whole other project within a project.
Yeah, I imagine that it is a huge challenge, but I just thought it would be useful to, you know, pull back the curtain on that for learning for others that will be stepping into that arena very soon, I would imagine, in Belfast Trust. So if they can learn anything early doors, this is their opportunity to put some stuff in.
If there's two things you leave with, it's one, no training, no kidding, no access. Take that away home and think about it. And the second one is meet the date or escalate, and be very agile at doing that.
Okay. Thank you for your words of wisdom, Helen. We'll maybe check in with you the week before Christmas to see how you've survived go live and the initial couple of weeks afterwards. I'm sure there'll be many more ups and downs between now and then. Thank you for taking the time out today. I know you are really busy in South Eastern Trust, as are all the teams. I know Darren had to jump off to go back to his TDR. And Ratiel, I'm sure we'll be speaking to you again in the future when you've got more to share with us. Our next two sessions that we're doing on digital dispatches are also Encompass related, and they are actually people who are using the Epic solution in other environments. And one is a Belfast native who's a speech and language therapist and working out of Great Ormond Street. So watch for flyers coming out in the coming weeks. We'll have a session on the 27th of this month, and then one on the, I think it's the 6th of November. So look forward to seeing some of you back then, where you'll be able to speak to people who've had experience of actually having hands-on experience, and just 3 days before go live in South Eastern Trust. Thank you all again for your participation, and hope to see you all again next month.